Okay, we are going to get started and cover chapter 25, all about administering medications. So this chapter is long and there is a ton of information in it, and all of it is important and relevant to your practice. So I really encourage you to dig deeper into your chapter in these different concepts that I cover in this PowerPoint, as it is a lot of information. And one of our main jobs as nurses is to carry out physician orders, which include giving medications. Okay. So first we'll do a little pharmacology overview. You guys will have an entirely separate class all over pharmacology, but there will be some of these concepts on your exam. So make sure that you know these. So when we're talking about drugs, excuse me, drugs have multiple different names. So a chemical name. So what the chemical name is the exact description of the drug's chemical composition and molecular structure. Okay, so typically that one you don't see a ton used. Okay, but it does have a chemical name. And then there's a generic name. So this is one of the main ones that you're going to see. So this is like a non-proprietary name, and it's assigned by the United States Adopted Names Council. And when that happens, when it's developing manufacturer is ready to market the drug. Okay, so this is usually similar to a chemical name, but it is in a simpler form. Okay, so it's a little shorter. And this is the kind of name, the generic name is typically the one that you can't pronounce very well. Okay, it is always noted and spelled in a, like when you can notice the generic name from the trade name, because it's usually spelled with not a capital letter at the beginning. Now, an exception to that, of course, is this example that I used for some reason on this slide. So if you look at this, this will point out everything I'm trying to say. So the generic name here is erythromycin. Unfortunately, on this drug label, it's in all caps, so you can't tell. But if it wasn't in all caps, the erythromycin would not be capitalized. And that's how we kind of know it's a generic name. Okay. And again, harder to pronounce. The official name is also the generic name that is listed in publications in the United States, Pharmacopoeia. So with this one, when we're looking at the official name, it's not actually on my example, it looks like, but we also don't use the official name very often when we're talking about drugs. Okay. So the main two that we as nurses care about is the generic name, which is that erythromycin in this example, and then the brand name. So the brand name is the trade name. So this is what the drug is sold at in stores. Okay. Typically the brand name is going to be easily recognized and more easily pronounced. It always begins with a capital letter, unlike the generic name. So that's how you can tell the difference between the two. So for an easier example than the one that's in your book and on this slide would be the generic name for Tylenol is acetaminophen with a lowercase a at the beginning. And then the brand name for it is Tylenol with a capital T. It's Tylenol, easier to say than acetaminophen. Okay. And typically with the brand name, you're also going to see a trademark symbol at the very end. So with this one, you can see that, or not the trade name and brand name are interchangeable. So with this one, you'll see that the brand name is Iritab there at the top. Okay. It's important for you to realize that prescription drugs require a written prescription from a healthcare provider. So it has to be a physician or an advanced practice nurse who's operating under a physician. And then there's non-prescription drugs. So these are also called over-the-counter drugs. These may be purchased without a prescription and are assumed to be safe for the general population if consumers follow the manufacturer's directions. So mechanisms to promote drug safety. So there are reliable sources of drug information out there. So state and federal regulations and standards controlling drug administrations and a variety of systems for storing and distributing medications and healthcare agencies, they all work together to protect consumers. Okay, so the following are used when researching a medication or a drug. All of these listed here. So the pharmacopoeia or formularies, nursing drug handbooks, which you can see on the picture on this slide. A PDR or physician's drug reference. This is another resource. Any pharmacology textbook is a good resource. electronic and internet-based formularies. You can find all kinds of websites that tell you about different drugs. A good one and an app to have on your phone is the Hippocrates app. That one's very helpful. You can always go to a clinical pharmacist, whether it be one just at, the Payless pharmacy that you may use, or if it's one where you call the pharmacy when you're working on the floor. Also, medication package inserts and directions on the back of the box will help. And then obviously any institutional medication policies and procedures are there to help you as well. Legal considerations. So in the United States, drug administration is controlled by federal, state, or local laws. Okay, so standards of nursing care, state nurse practice acts, and organizational policies and procedures are going to define our role and responsibilities in administering medications. Okay. With the U.S. drug legislation, what they do is they set official drug standards for the drug. They define prescription drugs, what needs to be prescription, what does not. They're going to regulate those controlled substances, so those opiate, narcotics, and things like that. They're going to improve safety based on maybe side effects that have been reported or adverse reactions or things like that. And they require proof of efficiency. Okay. And then your nurse practice acts, again, this is kind of the governing body of nursing. Okay. And you guys will learn more about that when we get into week 7 and we talk about legal considerations as a nurse, but this is going to identify the nurse's role and responsibility for administering meds to a client. The Comprehensive Drug Abuse Prevention Act, this is going to control distribution and sales of controlled substances. The Durham-Humphrey Amendment, this approves labeling and prescriptions. And then the Harrison Narcotics Act, this is going to regulate drugs that can cause dependence. Okay, so a lot of that here in the United States, as we know that that's a problem. So also to be noted is the Food and Drug Administration of the U.S. Department of Health and Human Services. They regulate the manufacture and sale of all medications and monitors their safety and effectiveness. It also regulates through controlled clinical trials, the testing of any medication that's to be marketed in the United States. It's important for you to understand that a lot of medications that are sold over the counter, especially herbal supplements and things like that, vitamins, that kind of stuff sometimes, or most of the time actually, is not FDA approved. Okay, so this right here, this is a U.S. Controlled Substance Act here. So medications are classified by Schedule 1 through 6 when we're talking about controlled medications, okay? So it's a schedule of 1 through 6, depending on how strong of an addiction or dependence can be formed on these. So you can see on here, Schedule 1, what that means is there's no current legal medical use for these and a high potential for physical or psychological dependence. And so you can see drug examples. So things like heroin, LSD, things like that on here that are listed, MDMA or ecstasy. We know that we can get those on the street and that a lot of places have issues with those, but you're never going to see these given in a medical setting. However, I do want to note that also marijuana is listed on the Schedule 1 drug. This book was published a few years ago, and I would assume that upon new research and where our country is heading, that is going to change. But as of right now, it is still a Schedule 1 medication. However, you will see medical marijuana used in a practice setting. Things like in pill form, you may see Marinol, and they give that a lot for appetite stimulation for chemotherapy patients or just the elderly, things like that. So I did want to point that out. And then you can see Schedule 2. These are things like Adderall, cocaine, codeine, things that have restrictive legal and medical use, high potential for physical or psychological dependence, high risk for addiction abuse. And you can just kind of go through these yourself to kind of understand that, all the way down to Schedule 6, which is over-the-counter availability, which are legal without a prescription. So alcohol, aspirin, caffeine, things like that. So medication system. So you'll be able to get your medications in a variety of formats as you hit the floor as a nurse. Okay. So a stock supply, this means that you get it in bulk quantity. So stock supplies require that you measure each dose each time the patient needs it. So the potential for measurement error is present each time a dose is prepared, okay? However, a bulk supply of medication is also often very cost effective. So what that is, like maybe when you, maybe the patient has an order for liquid Tylenol, right? And so with that, your patient is sent a large bottle of maybe 1,000 mils of liquid Tylenol, but they only need 5 mils every single time that they get it. So every single time you pour and measure that medication to give to your patient, that risk for performing a med error is there every single time. So that's a stock supply, okay? Medications can also be given in a unit dose. So this is a locked mobile cart. When a locked or mobile cart is used, it typically has drawers containing separate compartments for each patient's medication. So extra drawers typically contain supplies like medication cups, syringes, alcohol swabs, things like that. And then you get a unit dose medication where it's individually packaged, it's client specific drawers in there, and it's typically a 24-hour supply. So typically limited amounts of PRN medications, or PRN means give as needed, okay, give according to patient need, right? So there's limited amounts of those PRN medications in the stock carts as well. And so with that, with the unit dosing, typically you'll see that in like a nursing home where they'll have what they call like patient rolls, and like each little tablet that they get is going to be individually packaged and given over a 24-hour period. So you'll have their 24 hours worth of meds, and then pharmacy may deliver again. A lot of times in the nursing home, you'll see this for a week at a time rather than a 24-hour period, but that's a unit dose. So what a unit dose means is it's the prescribed amount of the drug that the patient receives at a single time. Okay, so each unit dose, which is usually 1 tablet, is going to be individually packaged and labeled with the drug's name, dose, expiration date. Okay, typically checked by a pharmacist, and then you give that based on the order. Then there's an automated dispenser. So with these automated dispensing systems, this is a computerized system similar to a unit dose system. It's typically a locked cart containing all medications that are frequently used on a particular nursing unit so that they are available. The computer database contains records and counts of the medication, as well as the medication prescriptions for each patient on the unit. Medications are usually packaged in unit doses, so 1 tablet, 1 dose type thing. But some bulk medications may also be kept in the cart as well. This method allows for immediate administration of newly prescribed medications or PRN medications and things like that. And so typically these are password accessible, and it's a locked unit. It does have computerized tracking. So upon review, you can always see what nurse got out what med at what time, how many there were before they got them out, how many that's left after they got them out. And then typically with this, you'll see in a hospital setting, it's like a Pyxis or an Omnicell, I think is another brand. But that's what that is, automated dispenser. And then there's self-administration. So sometimes while in the hospital, patients may self-administer medications. For example, if they are given sublingual nitroglycerin, which nitroglycerin is a medication we'll probably talk about in lab, but sublingual is just a type of route. So that's where you put their medication underneath their tongue and it dissolves there. So for example, when patients are self-administering, sublingual nitroglycerin is used for chest pain. So that's a lot of times administered in the outpatient setting, and some patients can continue to self-administrate that while they're in the hospital. The drugs prescribed for self-administration are typically supplied in individual containers and stored at the bedside. That is not the norm, however, though, okay? And they do have to have special permission to be able to do that. So pharmacological considerations. So if you review on page 775, you're going to get this much more in-depth pharmacology. You're going to get this information much more in-depth in your pharmacology course. However, on page 775, there are a lot more of the basics to consider that you can kind of dive deeper into this little mini lecture that we are going over today. So when considering pharmacology and how drugs work in the body, we need to consider pharmacokinetics. Okay, so what this means is what happens to the drug inside the body. So how the body processes the drug, that's what pharmacokinetics is. Okay, so it's focused most of the drug and how it interacts with the body. So it refers to 4 steps. So number 1 being absorption of the drug, number 2 being distribution of the drug, number 3 being metabolism of the drug, and number 4 being excretion of the drug. Okay, so these 4 processes determine the intensity of and the duration of a drug's actions. Okay, so each drug has a unique pharmacokinetic characteristic. Okay. And then we talk about pharmacodynamics. So this looks at the complex interactions between the drug, the body, and the disease process. So for example, if a patient has an infection, pharmacodynamics are going to look at the interactions of the antibiotic that's ordered, the patient's body assessment, the lab results, and then the pathogen that's causing the infection. It's going to take into account all of those things. And then if you look here at my picture, it's going to compare and contrast pharmacokinetics to pharmacodynamics, okay? It's going to determine with pharmacodynamics, did you get a desirable or an undesirable outcome with it? And then we'll go a little bit deeper into those pharmacokinetics here in a moment on the next slide. And then one thing to consider as well with pharmacodynamics is it's going to cover the primary and secondary effects of the drug. So primary effects being what did the drug primarily do? And then what, did it do what we wanted it to do? And then secondary meaning what also happened, which may not have been what we wanted to happen, but we kind of knew that this happens also. And then we got this secondary effect. So a little deeper into pharmacokinetics. So absorption, remember, absorption refers to the movement of the drug from the site of administration into the bloodstream. So if you are giving a med orally and it goes into the mouth, then and it's a pain medication because your leg hurts, then it's going to move to the bloodstream to alleviate that pain, right? So absorption, movement of the drug from the site of administration into the bloodstream. So you can give a med orally. You could also give an injection, right? So you give a shot and that would be your site of injection. So the rate of absorption determines when a drug becomes available to exert its action. So absorption influences the metabolism and the excretion of the drug, okay? Absorption is going to depend on the route of administration. Some medications given certain ways work faster. The IV route or the intravenous route is always going to be the fastest absorbed medication and it's going to always work the quickest, okay, versus an injection or versus an oral medication because it goes directly into the bloodstream, right? So it's already absorbed the second you put it in there. Then there's distribution. So this is the transport of a drug in body fluids, which is usually the bloodstream, to the various tissues and organs of the body. So because blood goes to all parts of the body, theoretically, a drug can produce effects intended or unintended anywhere in the body, right? So the rate of distribution is going to depend on the adequacy of the local blood flow in the target area, which is the site where the drug effect is going to occur. So more vascular areas are going to have a faster rate of action. Distribution is also influenced by the permeability of those capillaries to the drug's molecules. Okay. Then there's metabolism. Okay, so metabolism is the chemical inactivation of the drug through its conversion into a more water-soluble compound or metabolites that can be excreted eventually from the body. Okay, so that's the breakdown of the medication, right? Once a medication reaches its site of action, it is metabolized or changed into an inactive form. Metabolism takes place mainly in the liver. That's important for you to know. Drug metabolism is going to take place mainly in the liver, but medications can also be detoxified in the kidneys, the blood plasma, the intestinal mucosa, and the lungs as well, but mainly in the liver. And then there's excretion. So for excretion to occur, drug molecules must be removed from their sites of action and eliminated from the body. So this is how we get that drug out of our body, right? Excretion. So drugs may be metabolized completely, partially, or not at all by the time they are excreted, okay? The following are common organs for excretion. And it's important for you to know that most excretion occurs in the kidneys, okay? Your kidneys are your big filter in your body. However, excretion can also be helped by the liver, the GI tract, the lungs, and then the exocrine glands as well. The renal system is the primary site of excretion, however. So if your patient has decreased renal function, you're going to really need to monitor for medication toxicity. That should always be a consideration for you when you think about that. So when we talk about factors that may affect these different processes, so what's going to affect the absorption rate? So the route of administration, like we talked about. So drugs are manufactured for a specific route of administration. So you may give it to your patient orally or sublingually, which means under the tongue, or buccally, which if you give a buccal medication, that's just inside the cheek where it just dissolves right there into those mucous membranes. You could give it as an inhalant, which is like an inhaler, right? So they breathe it in. It could be topical, which means it's put on the skin. So that could either be in a patch form or a cream. It could be enteral, which means it goes into like a G tube, a J tube, a PEG tube, an NG tube. Or you could give it parenteral, which remember that means going directly into the bloodstream or into like an injection site. So maybe your like they give your flu shot in your deltoid muscle and things like that. Depending on the route, these meds are absorbed at different rates. Okay. Also, drug solubility. This refers to the ability of a medication to be transformed into a liquid form. That can typically be absorbed into the bloodstream. That is going to affect absorption rates. So with that, there's something called enteric coated drugs. What these are drugs that cannot be decomposed by gastric secretions. The coating on these medications, so they're typically in tablet form, the coating on there prevents them from being diluted before it reaches the intestines. So in this way, the coating delays the action of the medication. It also decreases irritating side effects of the medication on the stomach. Okay, so like with an enteric coating medication, you would never want to crush that medication or have the patient chew it, because we want to keep that coating intact so that they can take it and it gets where it needs to go, and that's when it starts working. There's also something called a timed release medication. So these are medications that are formulated to dissolve slowly and release a little bit of medication over a period of several hours. So it may be a large dose that they get one time a day, and then that medication works in short spurts throughout the day to keep whatever stable. So if it's for their blood pressure, they get a large dose in the morning, and then it lets out a little bit at a time every day to keep, or throughout the day, over several hours, and keeps their blood pressure normal. All right, and then another factor affecting absorption would be blood flow. So medications are absorbed rapidly in areas where blood flow to the tissue is the greatest. For example, oral mucosa is very vascular. So that could mean when you're giving it sublingual, that's going to be absorbed faster than if you were to have your patient swallow it. Remember, sublingual is under the tongue. If you're giving it buccally, which inside that cheek and that mucous membrane, it's going to absorb faster than if you were having your patient swallow the medication. Okay. Now, keep in mind, you can only give sublingual medications that are made to be given sublingually. You can't take a normal Tylenol tablet that's meant to be swallowed and put it under your tongue and expect it to dissolve. They have to be created in that way. So I just want to clarify that. And then like areas with poor vascular supply, such as the skin or areas with a lot of scarring. So topical medications, these types of areas and routes are going to delay absorption. Okay, and then factors affecting distribution. So again, local blood flow. So the rate of distribution is going to depend on the adequacy of local blood flow in that target area, which is the site where the drug effect needs to occur. So it's also influenced by the permeability of the capillaries, like we talked about. can also be influenced by the protein binding capacity at the site. So for a given amount of a drug, some molecules bind to plasma proteins and the remainder will be free. Okay, for example, nearly all Tylenol or acetaminophen molecules are free in the bloodstream and are therefore pharmacologically active. But by contrast, about 99% of the anticoagulant, which means blood thinner, Coumadin or warfarin, if you've ever heard of that, 99% of that is bound with the blood. So its effects are produced by only 1% of the warfarin molecules that are actually free. Okay. It's very interesting. And then factors affecting metabolism. So liver function, that's a big one, right? Because the liver is the primary site for metabolism. So with that, if liver function is impaired due to liver disease or aging or anything like that, the drug is going to be eliminated more slowly and toxic levels may accumulate more quickly. Okay. And then there's something called the first pass effect. So with oral medications, those are typically absorbed from the GI tract and then they circulate through the liver before they reach the systemic circulation. Just remember, systemic means the general bloodstream, right? Many oral medications can be almost completely inactivated this way. This inactivation is known as the first pass effect. Okay, so for this reason, oral medications are formulated with a higher concentration of the drug than our parenteral medications. Okay, right? We're going to give a higher dose orally than we would if it was if we were directing it directly into the bloodstream for that reason, right? And then excretion, so the elimination of the drug. So for excretion to occur, those drug molecules must be removed from their sites of action and eliminated from the body. So drugs may be completely metabolized or not at all. So when we're talking about drug excretion and factors that may inhibit that or affect that, remember that excretion occurs mainly in the kidneys, correct? So any kind of decreased kidney function or renal disease or kidney disease, that's all going to affect that and the excretion and things like that. So you always think about kidneys, main filter, and that can definitely hinder that process. So let's test your knowledge. So the client has been on a low protein diet. This will most likely affect which pharmacokinetic process? Absorption, excretion, distribution, or metabolism? The correct answer is distribution. Remember that that's all about how a drug or something like a low protein diet, distribution is all about how a drug or something like a low protein diet affects the transport to tissues and organs. Okay, so remember the protein binding capacity that we talked about. So a low protein diet may actually lead to an inadequate level of those plasma proteins, which is going to affect that availability of the free drug. Like how we just talked about the Tylenol and how 99% of that is free and the Coumadin or warfarin, only 1% is free. Okay. All right. So concepts related to pharmacokinetics, right? So time until onset and peak. So the onset of action of a drug is the time needed for the drug concentration to reach a high enough blood level for its effects to appear, right? So the onset of action, don't make it any more complicated than it needs to be. The onset of action is when it starts to work, right? This is the minimum effective concentration of the drug, okay? So that's the onset of action. When the concentration of the medication is the highest in the blood, the medication has reached its peak action. Okay, so that's your onset and your peak. Your therapeutic range or level. So this is the concentration of the drug in the bloodstream that produces its desired effect without toxicity. That's your therapeutic range. Okay. Your peak level. This is going to occur when the drug is at its highest concentration or in the blood, right? So after the peak, the metabolic and excretion processes are going to begin to remove that drug from the blood and the tissues, right? So so you've got your peak, and then the body is going to work to try to excrete it. And then you're going to get your trough level. Okay. So your trough level is going to occur when the drug is at its lowest concentration, right before that next dose is due. Okay. And that's when it's going to definitely start to wear off. And that's the lowest it is. A lot of times you'll see labs order peak and trough levels with very toxic or potentially toxic medications, such as vancomycin. That's a big one. And it's important, which I think we'll talk about in a little bit, but it's important for you as the nurse to know that the peak is when it's the highest and the trough is when it's the lowest, right before the next dose, because a lot of times you will be the one carrying out the order to get a peak and trough level. And you need to know that you draw that trough level 30 minutes before that next dose, because if you go ahead and hang that next dose of vancomycin without drawing that trough, and then it's been infusing and then you draw it, you now don't have an accurate measurement of the trough level. Typically, you draw a trough level and you give it to the pharmacist, and that's what they use to dose the next medication to make sure that they're not overdosing. And then our drug's half-life. So this is a medication's biological half-life is the amount of time it takes for half of that drug to be eliminated from the body. Okay, we already know that elimination of a drug occurs in one of several places, mostly the renal system, but also hepatic and lungs and GI tract and things like that. So if we have a disease process occurring in the organ that eliminates that drug, it will have a longer half-life because excretion is impaired. So that's important when you talk about or think about dosing patients' medications, which is not your responsibility. However, as you will learn throughout this PowerPoint in this chapter, you are the last line of defense. So even if someone else orders a crazy dosage, you're expected to catch that error. And then the concentration of the active drug. So the effectiveness of a medication depends ultimately on its concentration at that intended site. Okay. And so there's my picture there about peak and trough. Okay, so that's where it's showing you in graph format, you're given that initial dose of the antibiotic, or let's say vancomycin, right? And then you've got that therapeutic level there, right? At your peak is the top of that therapeutic level. And then you've got your kidneys there saying that's high enough, we're getting toxic. And then it starts to go down to the trough level. So it gets to that trough level 30 minutes prior to that next dose. And then it says it's time for another dose. And that's how that works. So factors affecting pharmacokinetics. You can find this information on page 783 and 784. So age. So infants and little kiddos are going to require smaller doses because their body size is smaller. Elderly patients typically have lower functioning kidneys and livers, which can result in lower excretion and therefore toxicity of medications, right? So that could be a problem. Body mass or weight. So medication dosages are calculated for the average weight, which is about 150 pounds, right? So your 450-pound bariatric patient may require a much larger dose to reach those therapeutic levels. Gender, so hormones, body muscle mass, and differences between fat and water distribution is going to mean that meds have a different effect on men and women. Pregnancy, so there are drugs out there known to cause developmental defects to the fetus, and these are called teratogenic drugs, okay? So you need to remember that teratogenic medications need to be avoided in pregnancy because they can cause developmental defects to the fetus. Your environment. So heat and cold changes in peripheral vascular circulation can cause changes in absorption, especially in topical medications. So if you remember, as I've said before, when talking about vasodilation and vasoconstriction, those all affect the heat and the warmth and all of that. It's all tied together. And then all of that together with exposure to heat and cold can also increase or decrease the absorption of your medication, especially in topical routes, which are given on the skin, right? And then route of administration as well. So you be sure to look at table 25-1 on page 776 to 780, okay? This is going to tell you advantages and disadvantages of different administration routes, okay? And you need to know your administration routes, right? So then timing of administration, food and circadian rhythms can all alter absorption and excretion, okay? Fluids, so insufficient fluid or body water can interfere with absorption. Also, diseases that cause circulatory, hepatic, or renal dysfunction are going to interfere with this process. Genetic factors as well. Different groups are going to respond in different ways to medications. Your book gives the example of an Asian patient who may metabolize opiates at a slower rate. You can look into that in your book as well. And then psychological factors. So anxiety may cause resistance to tranquilizing drugs. And then there's also the placebo effect, if you've ever heard of that. So if a patient thinks that the medication is going to help, they will oftentimes feel better, even if the medication doesn't provide that help in all actuality. All right, and then pharmacodynamics. So when we're talking about that, so remember that pharmacodynamics is looking at how the medications achieve effectiveness by drug molecules interacting with those target cells. Okay, and then it also considers the biological response and then evaluates patient outcomes to the medication. Okay, so it takes all of that into consideration with pharmacodynamics. So here's some words and some definitions that you're going to kind of need to know as far as what are these primary effects of these drugs? What are we looking for? So a primary or therapeutic effect of medication are the effects that are predicted or intended and desired. Okay, it's what we want. So the primary effects, in short, are the reason that we're giving the drugs, right? So palliative effects. So what a palliative effect is going to be to relieve the signs and symptoms of a disease, but have no effect on the disease itself. Okay, so for example, giving opiates to a cancer patient. This is not going to treat their cancer, but it is going to treat their pain due to their cancer. A lot of times with palliative care or palliative drug administration, you are prioritizing the patient's comfort. That's what you're doing there. You are prioritizing the patient's comfort. So we're not treating them. We're not trying to cure them. We're just treating their pain or their discomfort to make them more comfortable. Supportive effects are going to support the integrity of body functions until other medications or treatments can become effective. So for example, when we get a patient that arrives in the ER that doesn't have a heart rate, we're going to treat the absence of the heart rate first, and then we'll figure out what caused it and administer medications to treat that issue. Okay, supportive medication. And then there is substitutive effects as well. So these replace either body fluids or a chemical required by the body for improved functioning. So for example, blood administration for a very anemic patient. And then there's chemotherapeutic effects. This is going to destroy disease-producing microorganisms and body cells. And we know that that's typically for cancer, right? And then there's restorative effects. This is going to return the body to or maintain the body at optimal levels of health. Okay, for example, protein supplements to our patients who are at risk for skin breakdown or malnutrition. Okay. So those were our primary effects. So now we're going to go over our secondary effects. So with secondary effects, these are unintended, non-therapeutic effects of a medication when we give it, okay? So there are different kinds of secondary effects, okay? So keep in mind that secondary effects can be predictable. I mean, we know that this is probably going to happen because it usually does. They can also be harmless, but they can also be harmful. Okay, so it could be any of these. And there's lots of drug research and knowledge out there for us to be able to at least go in with an educated guess. Okay. So the types of secondary effects. So side effects. These are unintended, often predictable, physiological effects that usually are well tolerated by patients, okay? You need to know the difference between side effects and adverse effects, okay? So side effects, unintended but often predictable physiological effects that are usually well tolerated, okay? They occur at the usual prescribed dose and may be immediate, such as dizziness, or they may be delayed, such as constipation, okay? For hospitalized patients, you will most often see side effects caused by analgesics, which are pain medication, antibiotics, and antipsychotics or sedatives, okay? The most common side effects are going to be nausea, vomiting, diarrhea, dizziness, drowsiness, dry mouth, abdominal distension, constipation, things like that. So for example, if I give my patient IV morphine, I know that this potent opioid is going to cause a histamine response. Okay, I know that. So I'm going to expect that the side effects are going to include some nausea. I'm going to expect that they might get a little itchy. They may get a little dizzy or drowsy or tired, and they might have a little slight drop in blood pressure. I know this going into that. That's not why I'm giving the medication. So it's not my primary effect. It's my secondary effect. And I know that it's going to happen. And it's going to be considered a side effect. Adverse reactions are going to be harmful, unintended, and usually unpredicted reactions to a drug administered at the normal dosage. Okay, so you can see box 25-1 for adverse drug reaction risk factors. These adverse effects are more severe than side effects and often require a discontinuation of the drug. Okay, the FDA defines severe adverse reaction as life-threatening and requiring intervention to prevent permanent impairment or death, and may lead to congenital anomaly, disability, hospitalization, or death. Okay, so health professionals must document serious adverse reactions according to agency policy. And then then the hospital goes through a whole thing of where to report that to. For example, remember that IV morphine I just gave that patient. Well, instead of the typical side effects we saw in the example, now the patient's complaining of mouth swelling, and then their blood pressure drops to 50/20 and they stop breathing. Now we've got an adverse effect. Then there's something called a toxic reaction. So these are dangerous, damaging effects to an organ or tissue. So toxicity may be caused by any of the following. So overdosing, giving too much of a medication, with examples including respiratory depression from excessive morphine, or hypoglycemia, so low blood glucose from too much insulin, right? That can happen with overdosing as far as that goes. Accumulation of the drug in the tissues related to long-term use or incomplete metabolism or excretion, that's going to cause it to build up. That can also be an issue. Then there's allergic reactions. So these are medications that most frequently there are different medications that most frequently cause allergic reactions, such as antibiotics or biological agents and things like that. The worst type of allergic reaction is called an anaphylactic reaction, which you will learn more about as you go through the program. So this is a life-threatening reaction that occurs immediately after administration of a medication. Typically, the pathophysiology of this experience is that you have a huge histamine response that affects the entire body. So one of the biggest worries is the constriction of the bronchioles with edema in the larynx and the pharynx, okay? So because of that histamine response that occurs with anaphylaxis, you're also going to see a big drop in their blood pressure. If the patient doesn't receive immediate treatment, they will probably die. Typically, treatment with this kind of a thing is going to be epinephrine, or definitely epinephrine, and then also possibly steroids or antihistamines, depending on the severity of it. They may even need to be intubated or put on a vent. And then idiosyncratic reactions. These are unexpected, abnormal, or peculiar responses to medications. So with that, they may take the form of extreme sensitivity to a medication, or maybe even a lack of response, or the opposite of the expected outcome, such as agitation in response to a sedative. This happens sometimes. We see this a lot with Benadryl, actually, sometimes. And then the cumulative effect. So this is an increased response to repeated doses of a drug that occurs when the rate of administration is greater than the rate of metabolism and excretion. Okay. For example, in premature infants, they typically have a lot of infections due to their immature immune systems. They may receive antibiotics. One that's frequently given is gentamicin. So gentamicin is excreted through the kidneys. So these preemies have immature body systems, and guess what? They have a tendency to not be able to properly excrete gentamicin and end up with toxic levels that can cause hearing damage and other things. And then drug interaction. So antagonistic reaction. So this happens when one drug interferes with the actions of another and then decreases that drug's effect. So it's a combined effect between two different drugs that is less than if one drug was giving alone. Okay. Then there's a synergistic effect. So this is when there's an additive effect. So the effect of two drugs giving together is greater than the individual effects of the drugs given alone. Okay. And we see this sometimes where doctors will prescribe two different meds to get that desired reaction of that increased synergistic interaction. And then drug incompatibility. So these occur when multiple drugs are mixed together and they cause a chemical deterioration of one or both of the drugs. Okay, so the result is an incompatible solution that should not be administered to your patient. So you can usually recognize an incompatibility because when the mixed solution when the solution is all mixed together, it takes on a changed appearance. So it may be cloudy, or it may have like crystals floating in it or something like that, but you should always consult a medication resource or compatibility chart or your pharmacist before you go mixing medications you know nothing about. So drug abuse or misuse. So you should be able to differentiate between these concepts and the concepts that describe a non-therapeutic use and effects of the drug in this way. So for that, see page 787, okay? Because you need to know the difference between these definitions here. So what is drug tolerance? So drug tolerance is a decreasing response to repeated doses of a medication. So this person often requires more of the drug to achieve the desired effect over time. So an example for this would be our cancer patients who may keep needing increased doses of opioids because they have been on them for so long. Okay, so that would be tolerance. Dependence is a person's reliance on or need for a drug. Okay, typically leads to compulsive patterns of drug use where the user's lifestyle centers on taking the drug. Okay, we all know what dependence is, right? Drug misuse is the nonspecific or improper use of drugs, including alcohol, over-the-counter medications, and prescription drugs. And then drug abuse is the inappropriate intake of a substance by amount, type, or situation continuously or periodically. Okay. Unfortunately, nurses have a high level of abuse. The State Board of Nursing have been doing a lot to research and create programs that help peers identify abusers as well as getting help for abusers as well. And then you need to know that the federal agency that handles drug investigations is going to be the DEA, the U.S. Drug Enforcement Agency. Okay. And then there's illicit drugs, also known as street drugs, which are sold illegally. Many might be prescription drugs like hydrocodone that are sought for their mood altering effects. Okay, so prescription drugs can be abused when taken for purposes that aren't medically necessary. So measuring and calculating drug dosages. So we know from our math class that we measure drug dosages. Okay, we're getting into the thick of it with that now. So medications are not always available in the exact dosage that the patient needs. Okay, so you must be proficient in calculating drug dosages and be sure that your patient is receiving the correct amount of medication. So with this, we know from all of our problems that we've done through this semester so far that medications are usually prescribed and measured using the metric system. However, a few are still dispensed in the apothecary system and the household system. So sometimes we need to make conversions from one measurement system to another, right? So the metric system, this is the preferred system to measure drug dosages because it promotes accuracy by allowing for calculation of small dosages, okay? A disadvantage of this system in the United States is that many people outside of the healthcare system are not familiar with it, okay? Then there's the apothecary system. So with this British apothecary system, it's the measurement that has been used in the United States since colonial times. Okay, only a few medications, such as maybe even only aspirin, are measured using this system because it's less convenient and less precise. Okay. Then there's the household system. So although it's easier to teach a patient about home medications using this system, this is talking about teaspoons, ounces, cups. Nurses often don't use this because drug dosages are less precise and can lead to medication dosing errors. And then there's units. So we know that insulin, which is a drug used by diabetics to help control blood sugar, insulin is measured in units, okay? With 100 international units, or U100, being the standard strength preparation. Okay, this means that you may get a bottle of insulin and the concentration on it is going to say that there's 100 units per mil. Okay. Heparin as well is also dosed in units. Okay. Be aware that not all units are the same. So for example, 1 mil of heparin does not contain 100 units of heparin. You must always read the container and the label to know the number of units per milliliter. Okay. And then there's milli equivalents. So these are going to indicate the strength of the ion concentration of the drug. A milli equivalent is the number of grams of a solid contained in 1 mil of a solution. So electrolytes such as potassium are measured in milli equivalents. You need to note that units and milli equivalents cannot be directly converted to the apothecary, metric, or household systems, okay? And then calculating dosages with ratios, solving for X, things like that. We go over that in math, so we're not going to go over that here. Here's a great video to help you with dimensional analysis and dosage calculations. Again, these won't play on my PowerPoint, so I'm going to skip this slide, but it is here for your reference. You know my love for registered nurse RN, and she does a great video on this if you still need help while practicing at home. And another. Okay. All right. So what are components of the medication order? Okay. So we started talking about this a little bit in chapter 18, and we'll do a little review here in this chapter as well. So you can see a little more information on page 788. All right. So what needs to be on the medication order? So this means, what does the physician give to you to tell you what medication to give and what has to be on that? So the client's full name, okay, the date and the time, the name of the medication, the dosage size, so how many mils or how many milligrams, the frequency, how often, Q6 hours, Q8 hours, Q2 hours, every day, and then the number of doses, how many total doses, right? And then the route of administration. Do you want us to give it orally, sublingually, topically? And then the printed name and signature of the prescriber, including relevant credentials and legal registration or DEA number. Okay, that's a written prescription. So when we're thinking about the medication order, so there are different types of medication orders. So there's a written order. So this is applied without a renewal date until the prescriber writes a prescription to alter or discontinue this medication. Okay. Then there's written orders that have an automatic stop date. So this is a protocol that hospitals use for discontinuing medications after a certain length of time. So most narcotic prescriptions are in effect for only 7 days or so in a hospital setting. So if the medication is needed after the automatic stop date, then the care provider must write another prescription. Then there's a stat order. So this means that a single dose of a medication is to be given immediately and only one time. Okay. And then there's a single or a one-time prescription order, right? And so this is going to indicate that the medication is to be given only one time and only at a specified time, usually before surgery or before a diagnostic procedure. Then there's something called a standing order. So these are officially accepted sets of prescriptions to be applied routinely by nurses to care for patients under certain conditions, under certain circumstances. So a lot of times on my unit, there will be I work on a labor unit. There's standing orders to do a vaginal exam on admission or to give 20 units of Pitocin right after delivery for bleeding. These are things that are there to protect the patient and give the nurse a little bit more autonomy, since typically the nurse is the one standing at the bedside. A PRN order. So a PRN prescription requires the nurse to determine in collaboration with the patient when this medication is supposed to be given. So typically the prescription is going to specify, firstly, the condition for which the medication is to be given. So give Tylenol, Q6 hours, PRN for pain, right? Given for pain. And then secondly, the minimum time intervals between dosages. So Tylenol, Q6 hours, PRN for pain. So when it's written like that, we know we're going to give it as needed only. We're not going to give it every 6 hours, but we know that if the patient asks for it at 2 o'clock and we give it to them, and then they ask for it again at 3 o'clock, we can't give it to them again because we have to wait 6 hours in between each PRN dosage when it's written like that. And then communication of orders. So it can be a handwritten order. So the order is handwritten or typed on a prescription form or pre-printed or something like that from the physician. They may be given to you orally. So when you receive a verbal prescription, which means maybe you're standing right with the doctor and they tell you with their words this prescription, then you're going to have to write it. So with that, you're going to write the prescription and you have to sign it with the provider's name, followed by your own name and your own credentials. Okay. Or maybe you'll get the order by telephone. You're on the telephone with them in the middle of the night and they give you an order. So usually this is going to be in response to a call that you have placed about report onto the patient. So you're allowed to take that order over the telephone. And then you'll write it out in the same way that you wrote your verbal order. And then the provider usually must co-sign the verbal and telephone orders within 24 hours. So it's important for you to know that when you're taking a verbal or a telephone order, that you always repeat and verify what the physician tells you. So if they tell you on the phone, hi, I want you to give her an order for acetaminophen, Q6 hours, PRN for pain. You're going to say to them, okay, doctor, I heard you say you want to give acetaminophen, Q6 hours, PRN for pain. Is that right? And they will say yes. And that's how you repeat and verify, okay? Just to make sure that there's no room for error there. And you will document that you repeated and verified that in the order. Let's test your knowledge. So the nurse is having difficulty deciphering the medication prescription written by the provider. What is the best strategy to clarify information? And you better believe this will happen to you. So A, ask the patient what medication the provider prescribed. B, call the pharmacist and ask him or her to read the prescription. C, ask the nurse who knows the provider's handwriting to read the prescription. Or D, call the provider and ask him or her to clarify the prescription. The only option that does not allow room for error is D, right? So let's play a curveball with this one. So let's say that you called the doctor and he's less than helpful and he's super mad at you and he says, stop bothering me, just read the prescription. He hangs up on you. So what's your next move? So your next move with that, you're going to move up that chain of command with your concern. Okay, always remember this if you have an issue. Go to your charge RN. If that doesn't work, go to your house supervisor, go to your unit manager, whatever. You need to report it, okay? And if this happens, this should be an incident report, okay? Physician incivility causes errors that the patients pay for, okay? Because nurses become afraid to clarify and collaborate. So this patient is the ultimate loser in this situation, unfortunately. So yes, always report this, file an incident report. All right, so let's test our knowledge again. So this nurse manager is investigating several near misses and an increase in medication errors on the unit. The nursing staff discusses that they are having a difficult time reading the handwriting of a particular provider. They convey that she becomes very annoyed when they ask her to clarify prescriptions that have on several occasions stated, I am sure you will figure it out. The nurses have been having other nurses interpret prescriptions. What's your initial actions? What is your safety concerns? And what options are available for the provider? So when we're thinking about this, the nurse manager needs to discuss the importance of therapeutic communication, interprofessional relationships, handling conflict, and expectations of each team member. So help the staff to understand that each nurse is accountable for her action and thus must have 100% accuracy in transcribing the prescriptions of providers. Okay, clarify and convey that it is the provider's responsibility to clarify the illegible prescriptions. So first, also, when we're thinking about this, the practice of asking other nurses to interpret a provider's prescriptions should stop, right? Because that just allows for more room for error. Explain that the provider must clarify her own prescriptions. The responses of the provider are not acceptable, so the nurse manager should discuss that situation with her. And then we're going to, the provider, there are obvious safety concerns with this, right? So we want to make sure that there's something that's going to work in the future. So maybe this provider in the future can print her prescriptions or something like that kind of gets rid of that user error. Or maybe they can do a computerized, just regular physician entry where they'll just enter it into the computer system that is available in lots of different places. So medication errors. So please see box 25-3 on page 794 in addition to your chapter reading. Okay, so when we talk about medication errors, this is a big deal. Okay, big deal. So medication errors they are made. Okay, the most common types of medication errors are listed here. So lack of knowledge of the drugs, okay, meaning giving incorrect dosing, incorrect mixing, overly giving too rapid of an infusion, or giving not knowing drug interactions. This is the most common factor contributing to medication errors. Maybe lack of information about the patient. So they didn't review the patient's allergies. They didn't review the other medications that they're taking. They didn't review the lab results or the medical condition where it's contraindicated. Or maybe the drug is given by the wrong route. Okay, never ever administer a medication that you don't understand its usage. Okay, there's so many easy ways to look it up. Faculty communication, or faulty communication, I'm sorry. Maybe the written prescription is unclear or illegible, like we just talked about, or maybe it's transcribed incorrectly. This results in administering the wrong drug or maybe the wrong dose, right? Maybe the telephone prescription is taken incorrectly, and then every nurse from that point forward is going to give the incorrect medication. Maybe the protocol is not understood or it's violated, or the drug prescription was written in the wrong patient's chart, or the wrong dosage is prescribed because somebody misplaced a zero, right? Maybe they didn't put their zero before the decimal, or maybe they put a 0 after the decimal, like you're not supposed to do, right? Maybe abbreviations are misunderstood, or there's poor or no documentation, okay? You must learn what is safe to use as an abbreviation and how to read and interpret other abbreviations. Maybe there's equipment errors. So the wrong equipment is used to administer the drug, or equipment malfunctions or is not used properly. And then calculation and measurement errors. So an error in calculating the dosage may be made, so the patient receives the wrong dose, or maybe there's confusion about a unit of measurement. For example, if a drug is prescribed based on how many kilograms the patient weighs, which we'll get into that later in the program, not in this class. And then it's dispensed or administered based on pounds, right? Which are not the same. Kilograms and pounds are not the same. That could overdose a patient, okay? Or maybe the medication is improperly handled or stored, or somebody didn't double check the patient's identity, or the lighting is inadequate and you read the label wrong, or the nurse is tired, okay? Another thing, the nurse is leaving the medication on the bedside table and then charting that it's been given without watching your patient take it. So what could go wrong with that? Maybe the patient forgets to take the medication, even though the MAR says that it's been done, right? Maybe the wrong patient could come in, somebody with dementia could come in, get that medication and take it, and then the wrong patient has gotten it. Or maybe someone might steal the medication if there's a pain medication in there that they want. So never ever leave your medication unattended. You give it to your patient and you watch them take it, and you don't chart that they took it until after they took it. Let me get back to this one real quick. And I just want to say that you will most likely make a medication error in your practice. I have myself, and almost every nurse that I know has. And it's just very, very important for you to understand that those types of medication errors, if you're not careful, if you get too busy, if you get too confident, they can kill people. These are people's moms, people's sisters, people's daughters that you're caring for. And it's important to take that job not lightly, okay? In healthcare, it doesn't really matter if the physician wrote the order for the wrong medication. It doesn't matter if the pharmacist approved the wrong medication. If it gets to the computer and you are about to give it to that patient and you give it, you check it and you give it, and it was the wrong medication or the wrong dosage, you're the one they go after. Legally, you're the one they go after, okay? You are the last line of defense is what nurses are considered. You are the last one that takes a look at that to make sure that it looks right before the patient gets it. So it's so important for you to double check and have mind your P's and Q's with this. And then the only other thing I wanted to say about this is to make sure that if you do notice that you have made a med error, do not be afraid to speak up, okay? Most of the time, you're not going to get fired for making a mistake, okay? But it is so important, because if you notice in a quick enough amount of time that you've given the wrong medication or too much of a medication, you can still do a lot to save your patient, okay? So that's very important that you're not too scared to own up to it. There has been lots of technology advances to prevent errors. So computerized prescriber order entry. So this is what we talked about a little bit a couple slides ago. So this helps prevent errors in transcription due to illegible handwriting. So the physicians put their own orders in the computer. They type them up, put them in the computer, and that's what we give, right? Barcode medication administration, which you'll see in almost all hospitals now, okay? Especially combined with CPOE. It provides the highly effective system for identifying the right patient, transfers data electronically, eliminates that error-prone paper transcription process and all of that. Smart pumps. So these Alaris pumps that we will show you in lab is what most hospitals are going to use. They typically help you by, they program dosages and common medications into these IV pumps, and then it's a system that helps save you. Okay, it helps save you from giving medication too fast or too slow and things like that. It's very helpful. And then automated dispensing cabinets. So these minimize human handling of drugs in the pharmacy. The pharmacy, they're known to reduce medication errors when the built-in safety features are actually used. And it's also important for you to remember that patients are typically pretty smart about what they take, so use them as a resource, okay? Don't let technology make you forget that the last safety check is your patient's understanding of their medications, okay? If the patient says that doesn't look like what I take at home, don't patronize them. Instead, do some research. It's most likely that you will notice that this does happen quite frequently in the hospital setting. They'll say, that pill is blue when I take it at home. Well, most of the time, it's the correct dose and the correct medications, but it's a different manufacturer. So it's important to let them know that. I understand your medication looks different at home, but I did a little bit of research. This pill looks like, it doesn't look like the one you take at home, but it's the same one because it's a different manufacturer, okay? What should I do if I commit a med error? So as a student, you're going to first notify your clinical instructor or your nurse if you're passing medications with her. Okay. But the very, very, very first thing you're going to do is immediately assess the patient's vital signs and physical status. Okay. And then you should know the side effects of the medication prior to administration. So you should be able to know what kind of effects you're going to look for. If you don't, look it up. Next, you're going to notify the physician and the charge nurse. Okay. You're going to follow any orders the physician prescribes related to the incident. For example, the patient may be transferred to ICU or labs need to be obtained or something like that. And then you're going to notify the nurse manager of your unit and report the events surrounding the event. Okay, check with the agency for the policy involving incident reporting. Okay, and we always want to make sure that we document the medication in the MAR, making sure that you include the dose given. For example, I gave 10 milligrams of IV push morphine instead of 1 milligram. So in the MAR, I will document that 10 milligrams was given. But never, ever do you document in the chart that a medication error was made. Okay. Instead, you just document the dose you gave, and you will be making a nursing note regarding calling the physician and administration of morphine, but you never say, I made a medication error in the charting. Lastly, again, we complete that incident report. So this is where the mistake portion is documented and everything surrounding the mistake. So it's in a different system handled by a different department typically. And this is typically where you're going to review your mistake, determine how and why it occurred, and how to prevent it from ever happening again. Okay. So giving medications, what are we going to do when we're giving medications? So during our initial patient assessment, we're going to gather data that we need to administer our medication safely. So the following are some highlights of medication-related assessments. So before we medicate our patient, we are going to check the patient's allergy list. Okay, that's super, super duper important. Okay, we always check the allergies before we give a medication. We also may measure vital signs depending on what kind of medication we're giving. So are we giving a medication for blood pressure? Well, obviously we want to know what the blood pressure is before we give it, because what if it's low? We don't want to lower it, right? We want to assess whether the patient's general condition is appropriate for the medication. If you check respirations on your patient or they're acting super lethargic and drowsy and tired and their respirations are 6, you think you're going to give your morphine? No, we know that morphine causes respiratory depression, so we're not going to give that medication at that time. We're going to evaluate our own knowledge about the medication, and that's everything we're going to do before administering our medication, right? And so while administering our medication, we're going to assess for mental status, their coordination, their ability to self-administer the drug, and their swallowing. Okay, make sure that they swallow the medication if it's oral, obviously. And then after we medicate the patient, we're going to monitor for effectiveness of the drug. So we gave a pain medication, they swallowed it, we come back 30 minutes later and we say, how is your pain? Rate it on a 1 to 10 scale so that we can see if it worked. We'll monitor for side effects and adverse reactions as well. Okay. We also want to always consider a medication history. So we want to make sure that we ask our patient about their history of illness, what medications do they take at home, any allergies, attitudes towards certain medications, learning needs, ask them if they're pregnant or breastfeeding, because that can also be a situation. And then the physical examination, again, like our vital signs and our patient's general appearance, we're going to use that to determine, are we going to give this medication right now? Is it appropriate? Here's some nursing diagnoses that are approved that would possibly fit for a patient who is getting medications, okay? And then our planning and outcomes, as usual, is going to depend on the actual diagnoses of our patient. So teaching medication self-administration. So remember that as a nurse, one of our primary jobs is to teach our patients so they can take care of themselves when we're not around. So we want them to know and understand what they're taking in order to take their drugs safely and effectively, right? So when you're prescribed a new medication, we want to encourage them, ask why you're taking it, ask how long you should take it, what side effects should you expect, whether you should take it with food, or ask about any special precautions, right? We want them to keep a list of their medications, including dosages and times that they were taken, right? We want them to take their drugs as prescribed. So take it in its prescribed dose for the entire length of time for the full effect. Remember, we never want people to take only 4 doses of their antibiotic because they feel better, right? We got our superbug going on with that, right? We want to remember that older adults may forget to take their medications. So a simple plan, coming up with a simple plan that they could follow at home, like a written schedule or one of those medication organizers or something. We want, if they can't see well, we want to encourage them to ask a family member to write their schedule out in large black letters or something. Make sure that they have glasses that are appropriate for them to see with. And some older adults even may take the medication and forget shortly after that they even did that. So maybe use a divided pill container like we talked about, or a small glass filled with the medications for each dose so they know when they took it or didn't. That way they didn't accidentally overdose on their medications. We want to encourage them to communicate with their prescriber. So notify your prescriber if you have any side effects or adverse reactions or questions. If you become pregnant, notify your primary health provider as soon as possible. So you should see if your meds should be discontinued or adjusted. We want to encourage them to think about their safety. So be aware of your safety and the safety of others. Wear a medical alert bracelet. Do not take medications prescribed to other people, and don't share your medications with others. If you take a variety of medications, post a list of them in a prominent place. Use child-proof caps if you have children who may have access to your medications. Dispose of expired medications safely. Do not place them in the trash. Disposing of them in the sink or toilet is not environmentally sound, as they can appear in the community water supply. Administer your drugs correctly, right? So read the label. Teach them how to read the label carefully. Tell them to be careful and read it on the bottle each time they take the medication so that they take the correct medication in the prescribed dose, right? Many of the tablets look alike. We want to make sure that they know to measure liquids, to use kitchen measuring spoons. We need to make sure that we do really, really exceptional teaching for patients with parenteral medications. So like insulin, right? So this includes when we're teaching about insulin administration, this is going to include teaching regarding injection sites and rotation of injection sites, right? It's important for patients who are on insulin because they're constantly giving themselves sometimes 3, 4, 5 shots a day. So when they're giving that to themselves in their fatty tissue or their subcutaneous tissue, it's important that we tell them that they shouldn't be giving themselves that shot in the same place every single time. They need to rotate their injection sites because giving it the same place can cause lipoatrophy, okay? We need to teach them how to correctly draw up the insulin into the correct syringe, okay? Insulin syringes always have an orange cap universally. You cannot, and I repeat, you cannot draw insulin up in any other syringe aside from an insulin syringe, okay? It will not work because insulin syringes are dosed in units and every other syringe is not, okay? You will overdose or underdose your patient if drawing insulin up in any other syringe. Then we want to teach them how to perform the injection as appropriate. And then we want to teach them to store their drugs safely. Don't store your drugs in a different container from the one it came in. Review the drug label and see it doesn't need to be refrigerated. And then teach them to maintain their supply. Check expiration dates. Do not take expired medications. Make sure that they get refills before they run out. Remember, this is super important for any type of medication administration and especially for your checkoff as well. You must do 3 checks when administering medication. So you check it before you pour. So what that means is you check the medication label against the entry on the MAR, which is either whatever you're looking at. MAR meaning medication administration record, okay? Be sure that the name, the route, the dose, and the time match the MAR entry, okay? So before you pour, you're doing your 3 checks, right? You're gonna check before you pour it. You're gonna check it after you pour it. Verify that label again against the MAR. And then you're gonna check it at the bedside right before you give it, okay? And that's all before you give your medication, right? You check it 3 times before it ever ends up in your patient's hands. So these are your 6 rights of medication administration. So if you follow these rights of medication administration, it means that you will give them the right medication to the right patient in the right dose, using the right route at the right time with the right documentation, okay? You need to know those. Those are the 6 rights. Other rights gonna be the right reason, the right to know, and the right to refuse. So the right reason meaning your patients have the right to not receive unnecessary medications, okay? For example, a tranquilizer or a sleeping pill should not be given because the patient is very anxious or cannot sleep, right? We don't give medications for the convenience of caregivers who are weary of his or her demands or something. The patients have the right to know. This means that you tell the patient the name of the medication, why it's being given, and potential side effects that they may feel. And your patient always has the right to refuse a medication, regardless of their reasons and regardless of the consequences. It's our job to educate them, but we cannot force them to do anything. So when we're talking about routes of medication administration, these are also important for us to know. So oral medications. This is the most commonly used route, and it includes tablets and capsules, which we all know what a tablet is, right? So we all know what a tablet is. And remember, those tablets can come in enteric coated. They can come in time release, right? And then capsules, those are where they have a little plastic coating that kind of slides together, and inside are like tiny little balls or powder or something of the sort. So that's a capsule. It could be a liquid medication. So these are frequently used for children and older adults. And these usually come in multi-dose bottles, right? So you have to pour it every time. So with that, when we're pouring medications, we have to hold the bottle so that the liquid does not run over the label and make it difficult to read later. And we always, always, always hold the cup at eye level when measuring. So that does not mean bring the cup up to your eye when measuring. It means lay your cup on the flat surface of the table and bring your eye to the cup. So you would be on bended knee at that point to ensure that you get the correct dosage. If you're holding the cup when you're pouring it, it's likely not an accurate measurement. Okay, so that's important to know. Buccal and sublingual medications. So although these are both placed in the mouth, these types of medications are intended for absorption in the mucous membranes rather than the GI tract. Okay, so some soluble forms of medications and enzyme preparations are administered by this route and are rapidly absorbed within seconds. So buccal medications are held in the cheek and sublingual medications are held under the tongue. There's also enteral medications. So these are for patients who cannot swallow or who have feeding tubes, right? So we're talking NG tube, OG tube, PEG tubes, things like that. Anything that's going directly into the stomach or the jejunal or the small intestine of anywhere. Excuse me. Remember that these tubes are long and narrow so that they can clog off very quickly. Okay, so whenever we're giving a medication via this route, the enteral route, we always flush after that medication with water. Super important. Other routes of administration. So topical medication, right? So applied directly to a body surface or cavity. So to enhance absorption, we're going to clean the patient's skin with soap and water and pat it dry before applying any types of creams or ointments, okay? So if you warm the medication in your gloved hands, it will become more comfortable for the patient and not as cold, right? Use a cotton swab or a tongue blade or a gloved hand to apply different kinds of medications because your body can absorb them just the same that their body can. So never do this without any type of PPE or something to protect yourself, because you will also get the effect of the medications if you don't. Transdermal patches. So these are designed to be absorbed through the skin, right? So these are transdermal, which means through the skin, right? And they're prepared as patches made of a special membrane, and the patches allow for constant controlled amounts of the medication to be released over 24 hours or more. Typically gives a prolonged systemic effect with patches, okay? So pain patches, if you've ever heard of a fentanyl patch, that's a big one that we see, especially in long-term care. And then local, meaning remember these types of topical medications can have local effects, right? So just in that area. So if you're giving a lidocaine cream, which is a pain ointment, you can just put that on it like your knee, if your knee hurts or whatever, right? And so that's kind of that with the transdermal patches. For eye medications, so ophthalmic ointments or ophthalmic solutions, so eye drops, right? These are used for their local effects to the eye, right? Used to treat eye irritations, infections, glaucoma, things like that. So for that, we're going to pull down the conjunctival sac of the eye, which is right there, where you just pull your eye down, you see that little sac there that's pink, right? And that's where we're going to drop it into that area. For eardrops, medications and solutions that are dropped into the ear may treat ear infections, okay? Use these solutions at room temperature, okay? Because these solutions that get too hot or too cold can cause problems with balance or nausea and even pain, okay? Our ears have a lot to do with all of that. If the solution has been refrigerated, make sure that we warm it by rubbing it between our hands for a minute or two before. Always remember that when you're giving an eardrop, if you are dealing with an adult, in the same way that when we assess the ears, we pull the adult's ear up and back to straighten that ear canal, and we pull the child's ear down and back to straighten that ear canal. And that's how you're going to administer those eardrops. If you're giving nasal medication, so usually clients will self-administer nasal drops or sprays. And they can usually use that they shrink the swollen mucous membranes, loosen secretions and things like that. And they just take a big sniff of the nasal spray, and they typically can do that themselves. Vaginal medications. So these type of medications come in various forms. So they could be foams or jellies, liquids, creams, tablets, suppositories, all of that. I give a lot of vaginal medications in my field, right? Because I'm trying to get kiddos out of their parents. I'm trying to make this baby come out of there, right? So a lot of times you'll see vaginal medications used for contraception or to induce labor, things like that. But you can also see it in patients with menopause who may have some like an estrogen cream or something like that for vaginal dryness or something. And then rectal medications. So these could be suppositories, which we'll go over in more detail in lab, and or liquid installations, which are enemas, for instance, if you've ever heard of that. and are typically used to encourage bowel movements or to treat some kind of systemic complaint. So typically with these, absorption is slow and erratic because of the rectal contents. So these are used quite often, truly. And then respiratory inhalation. So nebulization, this is the production of a fine spray or fog or powder or mist from a liquid drug. So typically the patient's going to inhale the medication mixture by breathing deeply through a mouthpiece attached to a nebulizer. Okay, if you've ever had a nebulizer, it's just this big aerosol machine. They put a little bit of liquid in this bottom part and they breathe it in either through a mask, typically through a mask or like a mouthpiece. When this happens, the airways and the alveoli are highly vascularized and they absorb that inhaled medication, causing typically them to breathe better is why they are getting this type of medication. And then you can also have atomizers, which these disperse the medication in the form of large droplets, or aerosols, which suspend the droplets of medication in a gas like oxygen, and a metered dose inhaler, which is a type of nebulizer that delivers measured dosage units of a nebulized drug. And we'll show you all of this stuff in lab as we get to that point. And then parenteral medications. So you can see this review on page 805. So parenteral medications include anything that you are injecting or infusing in the patient. They are wonderful because they are absorbed super quickly, the quickliest, okay? So they can be, however, they can also be terrible for you for that exact same reason. For instance, you make a mistake or the patient has allergic reaction and you administer it, it's done. It's already absorbed and we have, Houston, we have a problem, right? So with parenteral medications, we can be giving them, they are classified via their route, okay? So intradermal medications, these are medications that are given into the dermis of the skin, okay? That layer of the skin located beneath the skin surface, that's an intradermal injection. So the intradermal route is commonly used for allergy testing or tuberculosis testing if you've ever had a PPD or TB test, which we will be learning how to do, right? Most nurses use the patient's non-dominant arm for TB screening, but you can also use the chest or the upper back for intradermal injections as well. You need to know what an intradermal injection is and how to find the site as well. You need to know that, okay? Subcutaneous route. This is when medications are given into the subcutaneous tissue. So the subcutaneous tissue is the layer of fat located between the dermis and below the dermis and above the muscle tissue. Absorption is slower than through the intramuscular route because subcutaneous tissue does not have as rich of a blood supply as muscle, okay? However, the speed of absorption is going to vary with the subcutaneous site that you select, okay? When you're thinking subcutaneous sites, again, you need to know where to locate these subcutaneous injection sites. So this is going to be the fatty parts of the body. So either side of the abdomen, the fatty tissue there, the fatty tissue on the very, very back of the arm, the upper thighs. And I think we'll talk about that as we go forward as well. And then there's intramuscular injections as well. So these medications are absorbed faster than subcutaneous medications because they have a rich blood supply, right? Muscles can also tolerate more fluid. So you can give as much as 3 or 4 mils of liquid in a large muscle like the vastus lateralis and ventrogluteal muscles. The smaller the muscle, the less fluid it can tolerate. So again, you need to know intramuscular injection sites. You need to know where is the ventrogluteal muscle? How do I find it? Where's the vastus lateralis muscle? How do I find it? Because these are things you're going to definitely need to show competency for in lab, okay? IV medications, intravenous. So these medications are given through a catheter or a cannula inserted into a vein. Okay, we all know what an IV is. So these are given IV, right? So the onset of the medication action takes place within seconds. So IV administration is especially useful in emergencies, right? However, because an IV drug begins to act immediately, there is no way for you to stop its action if an adverse effect occurs, unless there is a known antidote to the medication. So that's where it can get a little scary. When we are giving, well, first I want to say that just as a side note, healthcare facilities do not reuse needles or syringes. Okay. Patients, sometimes you will see at home that they do reuse their needles and syringes due to cost. However, this is not recommended, first of all. And secondly, it's not ever a thing in healthcare. So one needle and then it goes directly in the sharps container. So you want to always be wary when you're giving parenteral medications. You want to know needle safety. You want to prevent needle stick injuries, okay? Because all of the parenteral medications require syringes and needles, it's important to consider safe disposal of your equipment, right? We never should be recapping needles, okay? Which means once we've stuck our patient, putting the lid back on. The majority of the needles that you are going to use in a healthcare setting are going to have a safety that you can activate, which prevents you having to recap the needle. However, if you are in a situation where you do have to recap a needle because you don't want to walk to the sharps container with an exposed needle, and you should not, and you do have to recap it, then you must use the one-handed scoop technique, which we'll teach you in lab, but that's where you just set the lid on the table, and then literally with one hand, don't use two hands to push it together, one hand to scoop it, okay? It decreases the risk of an injury, okay? We always dispose of needles and sharps in a sharps container. Do not ever stick a used needle into the trash, okay? Do not ever stick the syringe into a mattress. Never leave it on the side of the bed or bedside table, and never ever throw it into the garbage. Okay. So what equipment do you need for parenteral medication administration? So depending on the type of injection and the patient's size, you're going to need to know different needle sizes. So you can see table 25-6 for an overview. And it'll also be on your injections checkoff as well. And then, so you may need medication preparation. You may get a vial or an ampule. Okay, so an ampule, and this is just something that the medication comes in. So an ampule is a thin-walled disposable glass container with a narrow neck that you must snap off to access the medication. So it is made of glass. It is a glass thing, okay? Each ampule holds a single dose of medication because it doesn't have a lid. You literally break the glass to get it out, okay? So keep in mind, which you will learn this skill in lab, so you really don't need to like read about it a ton right now. So with an ampule, when you're breaking that, glass shards may go into the liquid medication. So you have to take out the medication with something called a filter needle, okay? And that filter needle is a huge needle, and it filters out the glass. And then once you're done with drawing up the medication, you take that filter needle off and you put on a regular injection needle, because you cannot give an injection with a filter needle. It is now full of glass because you just did that, and it's terrible. So don't ever give it with the filter needle, okay? We'll go over that more in lab. Or you'll be able to draw up from a vial. So a vial is a single dose or multi-dose plastic or glass container with a rubber stopper that's going to reseal the top after each time a needle is introduced. Okay. And so we'll go over that in lab as well. And then you maybe even need to reconstitute from a powder. So some medications are not stable as a solution, and instead are dispensed as powders inside vials. So there's no liquid, it's just a powder. So in order to reconstitute that medication, you add a diluent to the powder. Okay, you add normal saline or sterile water, or whatever it tells you to add, right? And so we will talk about that as well, but you just need to know, because we will deal with this in this class when we start to talk about this in math. It's important for you to know that the concentration of the drug is going to be dependent on how much solution you add when you're reconstituting medication. So you always follow the label, and the label will have clear instructions on how to reconstitute. All right, and sometimes there's mixing two medications into the same syringe. You will learn how to do this in lab as well when we mix different types of insulins. We can only do this if they're compatible. We can only do this if the total dose is with accepted limits and if they are both to be given by the same route, obviously. Okay, so we'll talk more about that when we get into lab about mixing insulins. So with safety issues, like we talked about, you must use Sharps containers. You must avoid recapping dirty needles. You must use the correct injection site. The wrong site could mean the wrong route. If you give a subcutaneous injection in the deltoid, you have now given nothing pretty much because you haven't even given it in the deltoid. You haven't been deep enough because you've got the wrong needle size. So you must know what your locations are. You must have those memorized. Okay. You need to understand the techniques required for each type of medication administration. Okay. And then you can see my little picture here. So Sarah is about to make a medication error. She is new and she's afraid to look stupid. She's going to administer potassium chloride IM instead of IV. I'm not really sure about the right route, but I don't think it will do much harm when giving IM. Helpful hints. Never assume if you are uncertain. It is okay to look stupid for the sake of someone's life. If you are unsure, there are resources available. Try talking to another coworker or the pharmacy. Some institutions have online information that can be helpful. Okay, so this can be a problem. Okay, so you don't ever want to just look stupid. I take that back if that's not what I meant to say. You never want to be afraid to look stupid because it can really save a person's life. All right, and then IV medication. So with an IV push medication, these type of medications are pushed directly into systemic circulation, right? Directly into the bloodstream. Many drugs given by IV push have a package insert that contains specific guidelines for the administration, typically between 1 and 10 minutes. Some IV push medications can be given quickly and some have to be given slowly because they can have detrimental effects on their hearing or their kidney function or something like that. So make sure that you read the package insert. Even just pushing over 1 minute can seem like a long time when you're doing that. So look at your watch, okay? Take note that IV push does not mean the same thing as give rapidly, because if given too rapidly, IV drugs, particularly potassium, for instance, can be quite dangerous, okay? Like they give IV push potassium to cause executions. So it can be very, very detrimental, okay? And then there's IV piggyback medication. So with this, an IV piggyback setup is a smaller secondary container that's connected to the primary infusion. And this setup kind of allows for an intermittent medication to be given, one that is not given over a continuous amount of time. So I'm going to explain this to you a little bit using this picture, but have no fear. We will go over this in person in lab and it will make a lot more sense. So when you're looking at this, it's showing you a secondary infusion. So if your patient is on just a regular primary infusion of IV fluids that they're getting all the time. So maybe normal saline just to keep them hydrated. That would be that blue bag right there. So that blue bag is hanging. They're getting that constantly. Well, now they also need to get amoxicillin or penicillin because they have an infection, right? So now we hang this yellow bag here and then we connect it into that other bag. And we're not giving amoxicillin all day. It's just a 30-minute infusion that we're going to give 3 times a day. So we're going to hang it there, connected to our primary bag. And then when you're hanging something piggyback, so it's basically piggybacking off the primary infusion, right? The important thing to know about an IV piggyback is that it has to be hanging higher than your primary infusion. Otherwise, it will not run. So put your IV piggyback bag up on the top of that, and then you just hang your primary solution lower than that, and it will run through. All right, test your knowledge. So when administering a drug via the parenteral route, the drug would be absorbed fastest if given per the intramuscular route. True or false? The answer is false. Absorption refers to the movement of the drug from the site of administration into the bloodstream. So therefore, IV is going to lead to instant absorption. I just want to note that this PowerPoint did not review your sites of injection administration. So you do need to know those. So you need to review those in your book. I do know that they're in there, and we will talk about them in lab as well. So subcutaneous injection sites, you need to know. Ventrogluteal injection site, or I'm sorry, intramuscular injection sites, you need to know. And then intradermal injection sites, you will need to know, and how to locate those as well. Okay. And that concludes this rather long lecture. I'm sorry it's so long, but it's very important for you to know. So